So I wanted to ask 3 questions to each of these speakers. And the ketamine, which also causes a side effect. I'm a pediatrician, and I am a pediatrician. I wanted to know, as ketamine also causes hallucinations and psychotic states, is it a question of dose? Because we see that we can have effects that are antipsychotic or psychotic effects. Is it related to the dose of ketamine used? And the second question, I wanted to know if the population of girls that with a high proportion of genetic causes of autism, is it a population that is identical to the population of boys? Because we see that girls are underdiagnosed with more severe forms, maybe. So I wanted to know if it was a matched population. And the third question, I wanted to know if we shouldn't reconsider the reference diagnostic tests, which I think are based on samples made of boys. Shouldn't we reconsider the diagnostic tests with a population that would be more representative and matched? Okay, let me address your first question on ketamine. Yes, it's a question related to dose. The dose used from anesthetic to psychotomimetic or as antidepressant in some cases. Well, you really need to almost swallow the microphone. So it's a question of dose for ketamine. And for several years now, the emergence of metabolites of ketamine, which are present in the body after exposure to ketamine, can also have effects that can be different from anesthetic is another case, but as antidepressant or tomimetic. Yes, but when once you've said that, it's not that simple because you have a cascade, a chemical cascade with side effects. So for the second question, with the monogenic forms in boys and girls with the NDD, we don't have the answers. I just showed you what we obtained and the genes that we are working on, but I cannot demonstrate differences in boys and girls in severity and in associated signs. And maybe we're not looking at the right thing at this stage, but a few genes seem to show that there are differences between boys and girls, where boys are more affected, but it's very marginal, and we do not have the statistical power at this stage because we have very small samples because it's rare diseases each time. I cannot really exclude that we would have differences in these monogenic forms, but at this stage we do not see a fundamental difference of severity in boys and girls. So this does not necessarily go in the direction of the girls can sort of escape this type of diagnosis, but for this monogenic type, clearly.
Yeah. So regarding the third question about whether we need to change any diagnostic thresholds for autism diagnostics, I think it depends on the measure that we're talking about. So if we're talking about the measure that has been used for diagnostics, but not necessarily created for the purpose of diagnosis, for example, the ADR and ADOS, they're super useful in ascertaining the information, and they're indeed, I think if you look at the validation sample of the diagnostic algorithm, they're biased towards more male individuals, but they're also biased towards lots of other racial, ethnic, and other socio-demographic background issues. So those algorithms are created for increasing reliability and also for the use of research. But they're not meant to be, if I dare to say that for Dr. Lord, I think they're not meant to be clinically diagnosing people. I mean, you don't diagnose a person with autism based on a suprathreshold ADOS score plus an ADAIR suprathreshold scores, because there could be many reasons to them. And there could also be many reasons to people who are subthreshold on both, but you have good enough clinical formulation or information to say, I think this person meets the criteria. So I think I would separate the clinical diagnosis from those two instruments, and that apply to other similar instruments like the 3DI or DISCO as well. Now, if it's population-based trait measure, that may be a slightly different story. Because, for example, the social responsiveness scale actually has a population-based norm, so the T-score is actually corrected for population differences. But again, you could argue whether that population is representative enough, but that's a general population sample. So if you're talking about social responsiveness scale, then the T-score itself is corrected for that differences in a way. But the same has not been done to some other dimensional trait scales so far. So I would only say that we still have quite a lot to do, but I would say for diagnosis, it's really for a clinician's summary of the information and the expert clinician's diagnosis as the gold standard.
Hello, I'm René Cassou. I'm a psychiatrist. And I would like to ask a question to Dr. Meng Lai. In CDC, we have 4.5% of autistic subjects in California. Is this a problem, a construct problem of a shift of paradigm in autism, or is it a lack of precision of the diagnostic criteria?
That is a brilliant question, and it's hard to argue one or the other way around because we don't have the ground truth. The prevalence rate is an observation that's happening. It's also reflecting what's happening in clinic. So I think what's happening across many regions of the world in terms of the increased rate is at the very least reflecting better recognition to some, but also likely reflecting, if we use the term overdiagnosis, that you lump a lot of things into the category, or you generalize the criteria too much. That's possible. I don't think we have solid data to say it's either or. My suspicion as a clinician is that I think it's both. That's why I think when we talk about nuanced phenotype, we need to still maintain the level of internal consistency of what we talk about autism. I would like to refer to Dr. Laurent Groc's idea about the prototypicality of autism, because I do think that's a useful concept to go back to the possible prototypical one, and then to see how far you're away from the prototypical one. But there needs to be some level of consistency, which is the dimension of prototypicality. I would say this is an evolving issue, and I think we are observing the numbers and then interpreting the numbers. But as researchers and clinicians, we think about the clinical need. We think about whether the person's experience has been rightly captured by the diagnosis. Is that helpful? Because that's the most important thing. If the diagnosis helps, then that's beneficial. And then as researchers, we need to be clear who we are researching, and then the findings needs to be interpreted against the definition used in that particular research.
Hello, I am Dominique Donnet-Camel. I am a parent, a member of the Arapi, and I have a very silly question to ask you, Mr. Groc. You told us that in the cases of psychosis that you study, you identified that the NMDA receptor is blocked by an auto-antibody, but at this stage you have not been able to identify. And on the other hand, you told us that by treating 1 or 2 people with immunosuppressant, you have had stunning results. So I have 2 questions. So first, we may not need the specific identity of these autoantibodies because they are treatments that exist. And the second thing is that these treatments are maybe accessible to many psychiatrists or many persons. They exist. They're not dangerous. They have been validated. So when this type of treatment will be accessible, it's a lay question. No, it's not a lay question. It's an essential question. It's an absolutely fundamental question. And I would just like to, before I respond to, I just would like to talk about the mechanism. The antibody does not block as such. It moves it around. It shifts it. I go in the synapse to participate in communication, and then sometimes I go out and I will recycle. And the receptor, it makes things absolutely chaotic. But when you remove the antibody, and this is what we learned from these pathologies, the system will be restored. This was not self-evident because you could imagine that if you disorganize the system, the neurons will be, die, or you have a degenerative disease. But the good news is that the patients can recover. The minute you remove the antibodies, the receptors will go to the right place and redo their work. So there's no death. It's not the end of the story. But what I think personally is that we need to move on stage by stage, step by step, and be very humble and prudent, because autoimmunity with antipsychotic, we've been there when lots of things have been said. Maybe there's not a direct link with the disorders in these patients, but with patients who have a specific antibody against this, we're talking about 10-20%. We're not talking about a whole population. But in other pathologies, and you know this very well, as much as I do, that on the spectrum, the presence of autoantibodies is something that has been known for quite some time, but we have problems of definition of the targets, the quantities, etc. But what I mean is that we need to be extremely prudent because you want to know what the target is, and it's not a question of saying, I don't care about the target, but the question of, is there an antibody in the blood in my patient with a neuronal target, a neural or neuronal target? It's not just any antibodies. In the course of life, we have more and more and more. We all have autoantibodies, but here it's an autoantibody against a target that is a neuron target, a living neuron. So the question is it an MDR? But if it is pathogenic, I can, in that case, move on to a immunotherapy treatment. But if it's a treatment used, it's not aspirin, but so you have to manage the cost-benefit or risk-benefit ratio that we need to study. What I mean today is that we are at the stage where we need to move step by step and define whether we have the means to detect the autoantibody that is specific to neuron targets. And if yes, can we propose treatments of immunotherapy treatments? The answer would be yes, but on this notion of detecting specific or non-specific, we're not there yet. We don't have all the methods. And I think that it would be a mistake to want to move really fast and say, well, okay, let's test and let's all get immunotherapy, just in case, and have it as a blanket thing. That wouldn't be good. The good news is that we're moving fast and moving fast. The thing that's tested, that started with this very narrow lane of encephalitis and psychosis, maybe we can widen the path and define subpopulations, not full populations, but this is where we stand. But we need to go step by step, not just say an autoantibody is something we all have. We have to add this parameter of the target neuron. Probably that in 5 years down the road, I will say different things because things will have moved. So I just wanted to add, there is a clinical trial right now in France that is being put in place on our population of our children with NDD, a subpopulation with very specific clinical criteria. And we will be able to have, in 2 or 3 years' time, better answers. So a question for Dr. Lay. I saw that most of the studies on comparisons between boys and girls is on the behavior, And sometimes we talk about the hypothesis of socialization, a different socialization, but my question is more, is this documented? Myself, I have, long years ago, I wrote a dissertation on nonverbal communication in very young children, and I demonstrated that there were differences between boys and girls, with girls looking more into the face, whereas boys were more avoidant and more in action. But the interesting thing was that I took the interactions with parents, and namely, we had a very strong effect in interactions between fathers and daughters, and fathers being very focused on the face of the girls, and almost an attitude of encouraging the small behaviors and mimics of girls. And this was an effect that was very strong. So I'm wondering now if we can have the same type of effect, if studies have been conducted on this with regard to ASD.
That's an amazing question. As far as I'm aware, I don't think the study specifically for behavioral characterization of autism goes into this depth yet. So we spoke about socialization impact as a possibility, but I don't think there is enough research direct into that, although the same line of research has happened in other fields than the phenotyping of autism in a way. I would strongly, this is my dream study, I would strongly encourage all of us to incorporate the environment-person interaction side of measurement into our future phenotyping or behavioral characterization of autism, because I don't think that's well captured. And I think there's another issue, especially in the more Anglophone literature, which is that historically and for right reason, people try to stay away from reinforcing the misconception that parent-child interaction causes autism, right? So there is a maybe unconscious avoidance to measure in detail about socialization experiences in autism phenotype, because you might be interpreting that wrongly to a causal relationship. But I would argue that if you think about what's shown to be helpful in early intervention, for example, the naturalistic behavioral developmental interaction, which is reinforcing child's interest and then leveraging that to interact, which is essentially interaction-based, right? So I think there's a lack of research that's taking on a developmental psychology approach, especially in the field of socialization and their impact on behavior, into the diagnostic or behavior characterization of autism longitudinally. So my point here is that I think we need more research to gain empirical data on socialization and how that has impacted a person's behavior presentation. So yeah, I would stop there. I think that's what we need to do in the future.
So hello, I am from Bordeaux. I just wanted to ask, the camouflage is not specific to autism disorder, it's more on impression management. Is this something that was studied already in the age of onset and the development of the children with ASD or neurotypical?
That's a brilliant question as well. So there are some studies attempting to look at the age of autism diagnosis and the level of self-reported camouflaging traits in adults. If I remember correctly, in the States. I don't think there's a strong correlation that's found in that study, but that's related to how you ascertain the sample to start with. I don't think we have enough study to say anything really with confidence about how this is related to the diagnosis of autism, because we don't know how to measure it properly and reliably in younger kids. So we actually don't know how the same construct can be operationalized and measured without a self-report. So I think the key there is that we are still quite preliminary in finding the consistency between different ways of measurement across the stages of life. So we can extrapolate the finding in adults into teenager for self-report. There are a few studies looking at that. It seems to be working okay in the UK, in the States, in Taiwan, but we need more study to look at that line. But extending that into younger age, I think we need more measurement development. I'm aware Dr. Laura Hall is co-creating a version of the CAT-Q with parents and caregivers that can extend into the younger age range. There might be a study that's coming out soon to show that. And then we need to look at longitudinal studies to see how they are correlated over time. So there are still quite a few steps to go.
I'm Jacqueline Nader, an Emeritus CNRS Research Director. I'm here. And my question is about imitation. Alternating imitate and be imitated has been shown to be a genuine communicative system, wonderfully efficient in pre-verbal toddlers and in non-verbal people in the autism spectrum. Here you speak of imitation as camoufling and pretending to be normal. How do you differentiate these different forms and functions of imitation? Which kind of measure do you use?